to prostate cancer. Now, the epidemiology of prostate cancer. It is the most common cancer in men, most common cancer in men after skin cancer. So it's the second most common after skin cancer. The mortality is second leading cause of cancer. Then you have the risk factors. The risk factors of prostate cancer is advanced age, obesity, high fat and low fiber diet. If the patient has mutations in BRCA1 and BRCA2, Lynch syndrome, then you have clinical manifestations. How will the patient present with if they have prostate cancer? Clinical manifestation, they will basically be asymptomatic. You won't see a symptom straight away, but you will have urine retention, hematuria, and bone metastasis. Okay. Staging and grading. Staging is TNM staging. Localized prostate cancer, for tumor confined to the prostate. When the tumor is confined to the prostate, you will give it T1 or T2. If the tumor has escaped the capsule, then you'll have to give it T3. If there is no involvement of lymph node, no involved, so the person will have like a T1, T2, T3, like this, and then N0, M0. Okay, then you have locally advanced prostate cancer, extension to seminal vesicle, which will be graded as T3B. Adjacent periprostatic tissue, that means the tumor has gone to tissues around the periphery of the prostate. It will get a T4 grading. Regional lymph nodes involvement will be called N1. No evidence of distal metastasis, M0, no metastasis. Okay. Now you have metastatic prostate cancer, which will have involvement of lymph node outside the true pelvis, will be called M1A. If it doesn't have involvement, it's a non-nodal region. Sorry, there is involvement of non-nodal region. Then you have M1B and C. B is for bone and C is for liver and adrenal glands. B is especially for the vertebral column, and the less common side is the liver and adrenal glands, which is staged at M1C. Now Gleason's pattern, actually score will come to that later. Pattern 1 is a small uniform glands. If you see small uniform glands, a little bit or something, then it's pattern 1. Pattern 2 is more stroma is between the glands. There is more like not glandular tissue but something else. By pattern 3, it gets really infiltrated. Pattern 4 will have irregular masses, neoplastic glands. Pattern 5, only occasional gland formation. So like the more that uniform glands you have, the lower the pattern number. The lesser, the further away you go from the gland formation, the more, the higher the number of Gleason's patterns it becomes. Now, what is a primary grade? Now, primary grade is when more than 50% of the total pattern seen is assigned as the dominant part of the tumor. So the 50% of the prostate gland, more than 50%, is a dominant pattern. So like they look the same. More than 50% of the tumor, if it looks the same, then it is a primary grade. Secondary grade tumor means next more frequent pattern is less than 50%, but at least 5% of the pattern of the total cancer observed. Over here you have less than 50% of total pattern seen as dominant pattern of the tumor. So half of the the tumor is not yet looking like a tumor, but at least 5% of the total cancer is observed. Okay. Secondary grades are if you have at least 5% of pattern present in the tumor. It has to be less than 50, but at least 5%. Tertiary grade is a small component of third pattern. So if you have 3 patterns, then it's a tertiary grade, small component of a third pattern. And Gleason score is when you have 2 most prevalent Gleason grades. So if I see there are 2 types of tumors, and I see one looks more like grade 3 and the other looks more like grade 4, so the Gleason score is 7. Okay, now we'll do diagnosis. How do you do diagnosis? You will first check the PSA level. PSA level should always be more than 4 nanograms per ml to be diagnosed with prostate cancer. Abnormal digital rectal examination. So you'll have to put your index through the anus and see the prostate. Then you have prostate biopsy, which confirms the diagnosis. The question is, what confirms the diagnosis of a prostate cancer? You'll have to say prostate biopsy. You'll also see serum alkaline phosphate in the blood because of bone metastasis, but only if there is bone metastasis. And for some reason, metastasis from prostate is osteoblastic. Okay, which means that the cancer cells have invaded bone and too many bone cells has formed. It's more about bone formation. Osteoblastic tumors are quite rare. Most of them you'll find is osteocytic, I think, but whatever. Now we have to do treatment. How do you treat them? First is to do androgen deprivation actually. Okay, you have to do androgen deprivation. When you have radical prostatectomy, you'll have to remove the prostate. With androgen deprivation, what will happen is that when you have less androgen, the prostate gland starts to atrophy. Radiation therapy helps, and then you have chemotherapy. Okay, so what's the precursor lesion for prostate cancer? Precursor lesion is prostate intraepithelial neoplasia, PIN. Prostate intraepithelial neoplasia. Okay, now what are the types of prostate cancer? The types of prostate cancer is 2. Adenomatous nodular hyperplasia. Okay, adenomatous nodular hyperplasia. So let's call it ANH. And acinar adenocarcinoma. Okay, acinar adenocarcinoma, AA. Acinar is like how the gland is looking like, and adenocarcinoma means like a cancer in a gland. So this is easy to remember. Okay, this is easy to remember. And adenomatous nodular hyperplasia, which just means like it's a growth of the cell, like the cells have become hyperplastic. Okay, now adenomatous nodular hyperplasia is mainly seen in older men, various size of nodules surrounding urethra, and you have decreased androgens, okay, increased estrogens in them. Androgen receptor have been upregulated, and dihydrosterone receptors are overexpressed. They're overexpressed under estrogenic stimulation. So basically they have a lot of estrogen there and decreased androgens. Estrogen overstimulation has caused the overexpression of dihydrotestosterone. Okay, and because you have decreased androgens, you have more of androgen receptor upregulation. Okay, now it is the time for, what does it look like macroscopically? It looks like an enlarged nodular prostate. This was already in the name, right? It was not adenomatous nodular hyperplasia. It was adenomatous nodular hyperplasia. So you have an enlarged nodular prostate. Histologically, you have hyperproliferation of glands of fibromuscular stroma. Yeah, hyperproliferation is a hyperplasia, hyperproliferation of glands of fibromuscular stroma, luminal cells and basal cells without atypia. There is no atypia. These are the two cells found in the prostate gland. Okay, now this one is cancerous. Acinar, that's what the glands look like. Adeno, because it's a gland. Carcinoma, because it's a cancerous gland of prostate. Fine. It's the second most common malignancy in men. Talked about it. It's a grade 4 on Gleason. Then you have PSA levels. This 2 to 4 is physiological. 3 to 10 is gray area, like borderline. Can be cancerous, cannot be cancerous. 10 to 30 nanograms per ml or liter, I think. I'm not sure. Let me check. Per ml. Okay. And if it's more than 30, then it's an extra prostatic spread. That means the tumor has left the prostate. Okay. Now, macroscopically, what does it look like? It looks like it's yellow, whitish, and firm. The peripheral part, often dorsal aspect. Okay. So it's mainly in the peripheral part of the prostate, or sometimes I think in the dorsal aspect, like either peripheral or dorsal. Microscopically, it is densely packed. Okay, single lead, pale cuboidal or columnar epithelium, loss of basal cells. Okay, nuclear atypia with prominent nucleoli. Intraluminal crystalloids and hypereosinophilic secretion. Malignant loose myoepithelial layer, very important. Like you lose the myoepithelial layer when it's malignant. Now common invasion is perineural invasion, very common. It's typical, and bone metastasis, which is osteoblastic as discussed. Metastatic spread to the bone, osteoblastic. Okay. Ta-da!